Still, I hope you have some stamina for the tricuspid and infective endocarditis. I have enjoyed a recent presentation by Dr. Haytham Albar on the tricuspid valve, and it was amazing. I'm not sure if I will be able to present something similar. The tricuspid valve, what I'm going to share is just some perspective on this valve. We know that severe tricuspid valve regurgitation is associated with increased morbidity and mortality. And the 3-year survival of a patient who has severe or moderate tricuspid valve regurgitation is only 50%. And we also that the overwhelming majority of tricuspid valve surgery is performed during concomitant left side valve surgery. And let's name it concomitant with mitral valve surgery. The numbers related to tricuspid valve surgery are very sobering. 37% eventually develop severe tricuspid valve regurgitation following rheumatic mitral valve replacement. And 74% had moderate to severe TR 3 years after ischemic mitral valve repair surgery. The mortality of repeat surgery on the tricuspid valve surgery is very high, almost prohibitive. In the hands of German experts, Frederick Moore, 14% of patients who had surgery for the tricuspid valve after mitral valve replacement was 14%. That's an average between 8.8% and 18%. Only 40% of those patients live for 5 years. What is the volume of tricuspid valve disease? And the statistics are for the United States. 1.6 million live with significant tricuspid valve regurgitation in the United States. And we know that the mortality of these patients is very high. And how much surgeons perform annually in the United States, they do only 8,000 surgeries annually. It tells you that there is an unmet need for tricuspid valve surgery, and probably there are a lot of difficulties in decision-making and fear of outcome in these cases. The anatomy and physiology of the tricuspid valve are very important for surgeons. The tricuspid valve is the largest of the 4 cardiac valves with an area of 7 to 8 centimeters square. It is the most apically displaced valve among all the 4. The annulus of the tricuspid is non-planar. It is D-shaped in diastole. And the most important fact in the physiology of the tricuspid valve is that the annular dimension change about 30% between systole and diastole. And when it is pathological, it functions on the diastolic dimensions. So in systole and diastole, both the dimensions are enlarged. This is a morphology specimen examining the tricuspid valve annulus digitally by the right index. And it is demonstrating the relationship of the aortic root to the aortic segment of the tricuspid valve annulus. And you see, this is very relevant to the surgeons, and it's an important relationship. Moreover, this video of morphology demonstrates the distensibility of the anterior and posterior annulus, which is not supported by the fibrous skeleton of the heart. The tricuspid valve typically has 3 leaflets, the largest of which is the anterior leaflet, second largest the posterior leaflet, and then the septal leaflet. Like we said, it is non-planar. So the annulus of the tricuspid valve is divided into 4 parts. Starting from, I don't know if you can see the cursor.
We can see it, yeah.
Okay. So the annulus is divided in 4 parts. The first part of the annulus here, starting from the anteroposterior commissure, anteroseptal commissure, is called the aortic segment of the tricuspid valve annulus. So it corresponds to the aortic root. Then you have the anterior segment. It ends at the anteroposterior commissure. Then you have the posterior segment of the annulus extends all the way through the attachment of the posterior leaflet, and the fourth segment is the septal segment corresponding to the attachment of the septal leaflet. The tricuspid valve has 3 papillary muscles supporting the leaflets. The anterior is the most important and bulky, and it's relevant to us because we size the tricuspid valve based on the chordae attached to that papillary muscles and the posterior papillary muscles, and there are some multiple small septal papillary muscles. You can collectively call them the septal papillary muscle. By far, one of the most important relationships for the tricuspid valve is the conduction system, which hides inside what people call the triangle of Koch. It is the AV node and the bundle of His. The AV node settles in within the triangle of Koch. The triangle of Koch, as we all know, is formed by the attachment of the septal leaflet and the coronary sinus and the tendon of Tedero. The tendon of Tedero is formed by the fusion of the Sebacean valve and the Eustachian valve and extends medially to join the fibrous trigone, the posteromedial fibrous trigone. So this triangle, knowledge of this triangle is not just to avoid suturing there, it is to avoid anything touching that triangle. No suckers, no touching by forceps. It should be totally respected. Because as we know, when we do surgery on the tricuspid valve, most of the time we are not sure if we are helping the patient. So we should at least not cause harm. So knowledge of these anatomical relationships are very important. This is an additional morphology specimens for the tricuspid valve. It shows you the aortic segment, how closely related is. It's only separated by few fibers from the non-coronary sinus and the aortic valve. So these complications can happen, and we have seen it related to inadvertent injury of the aortic root in this region. Etiology of the tricuspid valve, the panel of etiologies is huge, and it starts with rare things and then the less common, the more common things. So you will be surprised to know that 80% of the surgeon's work lies only in half line of all these etiological factors. Look with me at the secondary tricuspid valve regurgitation, left-sided heart disease. So the surgeon's work is not entirely in this part. It is about 75 to 80% of the surgeon's work lies in tricuspid valve in association with mitral valve, not the aortic, not LV ventricular dysfunction. Because tricuspid valve in the setting of aortic valve or LV dysfunction is a different pathology. And you have pulmonary arterial hypertension from any cause. You have RV dysfunction from any cause. And what was called idiopathic tricuspid valve regurgitation is now explained by the presence of atrial fibrillation. So this is a list of etiologies the surgeons deal with, but still you should know the primary tricuspid regurgitation causes, congenital and acquired, especially trauma and rheumatic heart disease. You should know something about Epstein anomaly and pacemaker-related tricuspid dysfunction and carcinoid syndrome. This slide is titled Grading of Tricuspid Valve Regurgitation. Actually, is grading tricuspid valve dysfunction. And now the tricuspid valve regurgitation is only a part of the dysfunction. It's not only the regurgitation that makes you take the decision. There are other factors. And they have put 3 factors that are taken into account when you grade the tricuspid valve pathology. This is the regurgitation itself, the annular dilatation, and the leaflet coaptation. So in stage 1, you get none or mild tricuspid valve regurgitation, you have an annular diameter less than 40 millimeters. This is on echocardiography, and coaptation mode body to body, means good coaptation, no regurgitation, no annular dilatation. And stage 2 is mild to moderate regurgitation, annular diameter more than 40, and the coaptation mode is edge to edge. Stage 3 is severe tricuspid valve regurgitation with annular diameter more than 40, and coaptation mode, no coaptation. So this is basically, it doesn't talk too much to the surgeons because it's basically an echocardiographic grading. This is another newly proposed grading for tricuspid valve regurgitation. They have extended the classical mild, moderate to severe. They have added more to it, massive and torrential. And for us as surgeons, anything beyond severe carries the same guidelines. So torrential and severe are the same. You have to address all if you have to. There is no talk on tricuspid valve regurgitation without knowing the landmark trial or study of Jill Dravis in 2005. Actually, this study has produced a religious number of 40 millimeters for the annular diameter, or 70 intraoperative tricuspid annular diameter. Actually, it has become religious not because of it is being a fact, because people did not have numbers, and what is not measured cannot be improved. So this was basically the first number in the tricuspid valve surgery history that has come out. It might be wrong, it might be right, time will tell, we are not yet sure. But it is all over the place in tricuspid valve decision-making and in the guidelines. The annulus being a very important thing to take into consideration. If you are presented with a case of mitral valve who needs surgery, and you want to see the annulus, because the tricuspid valve regurgitation is not severe. If it is severe, you don't have to look into the annular diameter, as we know. But if it is mild to moderate, then you need to know the annulus. Usually, echocardiographic report overlook this, and transthoracic echoes, on which we base our decisions, underestimate very much the tricuspid valve annular diameter. So if you have, basically, because nearly 70% of patients who have mitral stenosis have some sort of tricuspid valve regurgitation, according to a report by Dr. Carpentier of 150 cases. So if you have a mitral stenosis cases you want to decide about, I think people should have time with the echocardiographer to have a look at the tricuspid annulus by not the standard views of the tricuspid annulus. It's very much underestimated the annular diameter. There is an apical RV focus view. That shows you the apex of the RV. It gives you approximately less underestimation of the tricuspid valve annulus. And if the patient is doing transesophageal echo, the transesophageal echo again struggles with getting the anteroseptal and anteroposterior diameter, commissural dimensions, which is the largest dimension of the tricuspid valve. To get that on TE, you know you cannot see the regurgitation, but you need to measure the annulus. In mid-esophageal 4-chamber view, you need to see the coronary sinus, and that approximately gives you a good assessment of the tricuspid valve annular diameter. Again, you look for the annular diameter if you don't have a severe tricuspid valve regurgitation. If you have a severe tricuspid, you already know that you have to fix it. Now, the surgical indications and guidelines. When you look at the guidelines of any disease, you want to look into the facts of it. The facts are established facts based on trials. So the facts in any guidelines are the class 1, which are are green, and the class 3, which are red. So those are facts. And anything in the middle is a recommendation that has not yet been established as a fact. So in the tricuspid valve guidelines, you can see only 2 greens. And on those 2 greens, you can actually make them 1 green. And you don't have any red. That tells you the positive of data that makes a guided decision in tricuspid valve surgery. So what are the greens? If you have severe tricuspid valve regurgitation, being primary or secondary at the time of left heart surgery, the tricuspid valve has to be addressed. And if you have asymptomatic severe tricuspid valve regurgitation, and it is functional, you have to address it at the time of tricuspid valve surgery. If it is primary and it is severe asymptomatic, you look into the progression of RV dysfunction. If the right atrium, right ventricle start to dilate, then you have to, it is class 2B, you probably could address that primary tricuspid valve regurgitation. The question comes on a TR, which is mild to moderate. If it is mild to moderate, then you consider other factors. What is written here is the pulmonary hypertension and tricuspid annular dilatation. And I think there is more to this. It's not only pulmonary hypertension and tricuspid annular dilatation. You look into the history also. If the patient ever had signs and symptoms of right heart failure, repeating edema, admitted and decongested, and then things became all right, that tells you this patient probably had a severe TR at one point. And the TR is affected by the loading conditions of the patient. So this is, so look into the history of congestive heart failure. Previous reports of echo, if ever tricuspid valve regurgitation was documented, atrial fibrillation, pulmonary hypertension, tricuspid annular dilatation. And if in doubt, don't rely on the echo, you decide intraoperatively by systematically examining the tricuspid valve. These are still some recommendations on the tricuspid valve surgery. The recommendation on the tricuspid valve stenosis, consider only severe tricuspid valve stenosis, no mild and moderate have any guidelines. So if you have severe symptomatic tricuspid stenosis, you address it whether with or without left side heart surgery. If it is asymptomatic and severe, you address it at the time of left side heart surgery. And if it's moderate or mild, you don't know. Nobody tells you unless you ask somebody on the spot. This is the algorithm on the left side of the screen is quite nice. If you are examining a patient who has severe tricuspid valve, tricuspid valve regurgitation, you just ask yourself, does he need a left side heart surgery? So he has tricuspid valve regurgitation, and you want to guide yourself. If he needs left side heart surgery, then what kind of tricuspid valve regurgitation you have? If it is severe, primary or secondary TR, you fix the tricuspid valve. If it is not severe, however, mild to moderate, then the same things apply. Look into the history of congestive heart failure, echo parameters for tricuspid valve annulus, and don't take any echo report. You have to go actively and ask for the views that tells you that do not underestimate or give you approximately the actual diameter. And then you can address the tricuspid valve if it is mild to moderate with signs of pulmonary hypertension, atrial fibrillation, or previous congestive heart failure. If the patient doesn't need left side heart surgery, however, if you have severe primary tricuspid valve regurgitation and it is symptomatic, probably that should be addressed earlier before you get RV dysfunction. If it is severe and secondary or functional tricuspid valve regurgitation, This is the most difficult type of patient. It is secondary and it is severe, and the patient doesn't need left side heart surgery. You have to know more about this kind of patients. We look at the RV and LV dysfunction, look for absence of severe pulmonary hypertension. Actually, you need to know, you want to operate on them, but you need to know why not to operate on them. Basically, if you have severe LV dysfunction or RV dysfunction, most likely these patients go for conservative treatment. The setup for surgery for the tricuspid valve is sternotomy, thoracotomy, mini thoracotomy. They are all reasonable approaches, depend on the surgeon's preference. It is preferred to do full sternotomy for tricuspid valve endocarditis, especially because if you need to remove leads and you do good reconstruction and examine other valves as well. Cardiopulmonary bypass is necessary. The heart can be arrested or on a beating heart, depending on the surgeon preference. Cable snares are essential. The settings change when you are doing a redo tricuspid valve surgery. Cannulation would be peripheral. Issues with the snaring the KV can be there in a redo surgery, especially putting in an IV snare with the presence of adhesions. You can look for alternatives for snaring the KV by putting, inflating a balloon inside, or just shovel anything in the orifice of the IVC. Remember that when you are doing tricuspid valve repair or replacement, always have a plan for pacing, and especially if you are doing tricuspid valve replacement, you should beforehand have a plan for permanent pacemaker replacement, either permanent epicardial leads. And now we know there are leadless pacer. Discuss with the EP feasibility and access for this patient and availability of leadless pacemaker in case it is needed. Variable techniques have evolved over the time to address the tricuspid valve regurgitations and pathology. Bicuspidization did not address the annulus because we know most of the pathology is related to the annular dilatation. So it's not a good fix and it's not durable to do just bicuspidization. You could do it in an old, frail patient in whom you don't want to do too much. And the Vega technique, it addresses the annular. It does reduce the annular orifice, but again, it failed. And probably the reason of failure is the lack of remodeling of the annulus in the Vega technique. You just narrow the annulus down, but you don't remodel it with a specially designed ring. Other techniques depends on the pathology. If you have a focal leaflet pathology in trauma or infective endocarditis, excisions, patching, excisions, primary repair are all feasible, but all repair should be supported by annuloplasty. The most common operation performed on the tricuspid valve surgery is the remodeling tricuspid valve annuloplasty. All surgeons should know this. They should know how to size for placing this ring. Sizing is not only for placing a ring, sizing is also for assessment. If you are going in for a mild to moderate and you are not convinced or you don't have a good echo report, then you size the annular, the annulus by itself, and size the leaflet tissue and see the difference. If the annular is more than 2 sizes than the leaflet, then you decide to do annuloplasty. So the sizing was described by Carpentier, and people followed Carpentier throughout in this. Carpentier started with using the notched sizer. The notch sizer has 2 notches. The notches correspond to the anteroseptal commissure and the posterior commissure. So you place the notches over there, and then you stretch. Carpentier started with stretching the anterior leaflet And then he found that difficult because not all the chordae are attached to the coming from the anterior papillary muscle. Then he changed to grabbing all the chordae tendineae coming from the anterior papillary muscles, and that will stretch with you most of the anterior leaflet and part of the posterior leaflet. So that leaflet tissue, you stretch it and size it over the sizer, place it on the sizer. If it is the same size, then you use the same sizer you have used. If it is less, then you use the next smaller sizer. This is the way the tricuspid ring is sized. Then the placement of suture is straightforward, just putting in mind the anatomical relationship, respecting the area, the septal attachment of the septal leaflet, and the end of the ring are actually 6 o'clock and 9 or 8, depending on the anatomy of the patient. Most important is do not leave tricuspid valve stenosis. Tricuspid valve stenosis, this is what is meant by cause no harm. Cause no harm, respect relationship of the tricuspid valve, and do not leave stenosis. Stenosis doesn't have a treatment. It doesn't respond to diuresis, and it doesn't have percutaneous solutions like the mitral valve, as we know. And a Clover technique on the right side of the screen is the equivalent of the Alfieri stitch. It can supplement if you put annuloplasty, it's still not satisfactory. You can place an Alfieri or a Clover technique suture. There is a risk of causing stenosis though. The results of the tricuspid valve annuloplasty, they are quite good for flexible or physiological ring use annuloplasty if properly sized and respected. Failure of repair is related to use of perigard or posterior the bicuspidization. The Vega technique is a source of failure, presence of permanent pacemaker leads, and the initial degree of tricuspid valve regurgitation and LV ejection fraction at the start. These are the reasons for risk factors for failure of tricuspid valve annuloplasty. Please let me know if anything is not clear and my voice is not heard properly.
Assalamu alaikum. Sorry, Doctor, for interruption. Can you repeat the part of sizing in mild and moderate?
Sizing, yes. So there is, sizing to decide and sizing to do annuloplasty. So let's divide it into these two. Sizing to decide was proposed by Carpenter because there was not much echo and he was not convinced by echo reports most of the time. So he systematically examined almost all tricuspid valves, especially if they have history of congestive heart failure and the atrial fibrillation pulmonary heart. So he systematically go and examine the valve and decide about it if it doesn't have severe tricuspid valve regurgitation, mild to moderate. So he goes in, he sized the ring, the circumference, the annular circumference, and then sized the anterior and posterior, all the leaflet tissue coming from the anterior papillary muscles. That is mostly the anterior leaflet and part of the posterior leaflet. And then you have that surface area, you compare it with the surface area of the annulus. If it is 2 plus the surface area of the annulus, probably you don't need annuloplasty because you have enough tissue to cover that area. If, however, it is less, you address it. You address the tricuspid annulus. This is one way. The second way, you have already decided, but you need to know what type of ring you need to place. So you get the notch sizer, place the notches at the extremes of attachment of the septal leaflet. So one notch in the anteroseptal commissure, the other notch in the posteroseptal commissure. So that's the size you start with of the sizer. And then you take the surface of that sizer, compare it to the tissues coming from pulling the papillary muscles coming from the chordae coming from the anterior papillary muscle. If it is the same or larger than the sizer, that's that leaflet tissue. If it is larger than the sizer or the same, then that is the size you use for the ring. If it is the less, then you use a smaller sizer until you reach the size that covers the tissues coming from the pulling the papillary, the chordae coming from the anterior papillary muscle. Is it clear,
Yes.
Hussein?
Yes, thank you, Doctor.
It's okay, I can repeat it. I'm not sure if I explain it very well. The tricuspid valve replacement is usually, no people like tricuspid valve replacement, and it's only done in desperate situation where there is failure of reconstructive technique. It carries high mortality, risk of heart block, we know, and it does prevent future insertion of permanent pacemaker through the valve. And the choice between mechanical and bioprosthesis, because nobody randomized this patient, what they tell you is they exercise the same thing like you do in any other valves, considering age, contraindication to anticoagulation. But because in these cases you don't have randomization, if you ask the expert, when Carpentier was asked, he said, I would use a bioprosthesis even if I have a mechanical mitral valve prosthesis. So asking the expert is also an evidence. I myself prefer bioprosthesis in the tricuspid valve annulus, although putting a mechanical valve on the right side, if it gets stuck there, it's not as lethal as mitral aortic valve. It doesn't kill the patient immediately, and there is a chance of doing thrombolytic therapy for a stuck right side heart valve. But of course, you don't want that thing to happen. And also, if you place a mechanical valve in tricuspid valve position, you don't have much room to stop anticoagulation temporarily if that, in case that's needed for any reason. If the patient is going for any other procedures, or he gets a stroke, you want to stop it for some time. So you don't have much room if you have a mechanical tricuspid valve in position. Again, if you are replacing the tricuspid valve, it is essential to have a pacing strategy. Permanent epicardial leads before, make sure they are in the OR before you go in, or discuss with EP access availability of a leadless pacemaker and so forth. Pacing is very important. So it's not, this is a different type of pathology. It's not infrequent you are presented with a patient who had a previous mitral valve surgery of any kind, aortic valve surgery or CABG, and he has now severe tricuspid valve regurgitation with ascites, lower limb edema, JVP. These are very difficult patients. So it's a redo situation with only tricuspid valve. These patients, the best thing is to do is to admit them with cardiology or yourself to the hospital, because you need to know a lot before you decide whether to do a redo tricuspid valve surgery or not. You need to know if there is any residual left side pathology that's left behind, whether that needs to be readdressed or it is not addressable. You need to know the LV function, RV function, and you need to rule out if any patient had a previous surgery and has right side problems, you need to rule out constrictive pericarditis. And that requires a lot of studies, focus echo with expert right heart catheterization. And also if the tricuspid valve is severe, you need to know if the transvalvular leads are required, because that might be the only pathology. You might have to remove them or design a placement for them through the tricuspid valve. If the liver function is bad, most likely you are not going to take them for surgery, and you also have to rule out any abdominal malignancy. So it is a syndrome that requires a lot of workup before you decide to take these patients for a reoperative tricuspid valve surgery. And the decision is not so straightforward. So the question, because we don't have red in the guidelines, we don't have class 3, that's don't do on the guidelines. There must be some, because if you have 1.6 million in the United States who do not have surgery for the tricuspid valve, there must be some patients who in whom you cannot operate. But because of paucity of guidelines, you cannot label them red on guidelines without having data. In general, if the RV function and LV dysfunction is extreme, and you have severe pulmonary hypertension, it is unlikely that surgery on the tricuspid valve will change the prognosis of the patient. So don't look at the tricuspid valve alone. If you have extremes in other, in pulmonary hypertension and LV, RV dysfunction, you are not going to change the prognosis, and you are not going also to improve the symptoms. Unfortunately, they tell you severe RV dysfunction is a contraindication, not a contraindication, but it is not in favor of surgery. There is no threshold. You don't know what is severe RV dysfunction that contraindicate or prevent right heart surgery, tricuspid valve surgery. But what you can do if you admit those patients and you give them diuretics, they have lower lymphedema, ascites, you give them diuretics and you have a brisk response. You see their lower lymphedema is subsiding, liver function is getting better. Most likely these patients have some reserve and you can probably consider surgery. Now we come to the annulus. Like I said before, the annulus, when it came up with Professor Dreyfus and his group, people actually were not believing there is a number in cardiac surgery. People like numbers because it is science. The Tyron David and his group in Toronto were not so convinced, and they have looked into their patients who had surgery for degenerative mitral valve, and did not. Their central message was that a prospective preoperative tricuspid annular diameter more than 40 millimeters was not associated with the development of postoperative functional tricuspid valve regurgitation. So the annulus thing is really questionable. So if you are doing if you are opening the sternum, it doesn't mean you have to address all the severe tricuspid valve regurgitation, leave about mild to moderate. Here is a group of patients who have a chronic problem, and that is pulmonary thromboembolic disease. This would remind you of the pioneer of this surgery, Professor Jameson in San Diego. He's telling about his experience on pulmonary thromboendarterectomy, and this is done for type 3 pulmonary hypertension, type 4 pulmonary hypertension. He is telling about his experience on 1,500 cases of pulmonary endarterectomy. And he said tricuspid annuloplasty was not performed even when severe tricuspid valve regurgitation was documented preoperatively. So annular dilatation, severe tricuspid regurgitation, you are on bypass, you don't even open the right atrium. In the context of thromboembolic disease, being acute, we understand, because in acute pulmonary embolism, you get severe TR, you understand that that's an acute situation related to pressure load and volume load, and it comes back by itself. You just do the embolectomy and leave the tricuspid alone. But even if it is severe, you still leave it alone. And those who are in the business of pulmonary thromboendarterectomy, they don't address the tricuspid valve. This is supported by a recent paper from Thomas Manzel saying improvement of tricuspid valve regurgitation after pulmonary thromboendarterectomy. Talking about tricuspid valve, carcinoid heart disease mostly affects the tricuspid valve. we should know something about carcinoid. It is a neuroendocrine tumor of the midgut. It affects the heart in 20% of the cases. The biomarker is serotonin, and its metabolites 5-HIAA in the urine. It does cause tricuspid regurgitation, tricuspid stenosis, and pulmonary stenosis. It can affect the left side if there is a shunt from right to left. The surgery is done for symptoms relief. Nobody can prove survival benefit. It is one of the pathologies where the choice between mechanical and biological valve is difficult, because serotonin can still damage the biological valve. But still, I think you need to know with the endocrine people, if you are going through this case, if the patient has active carcinoid disease. Carcinoid crisis is an important thing to know if you are dealing with a case of tricuspid valve pathology related to carcinoid syndrome. And the treatment for carcinoid crisis, all patients should go when you have an octreotide available, because any stress can result in carcinoid crisis, not only stress or surgery. In conclusions, I think as surgeons, we have to pay a lot of respect to the anatomical relationships in the tricuspid valve, especially because when it is not severe, we are not sure if we are causing benefit. We are doing it just for the chance of having a better outcome. So we should not cause harm by knowing the triangle of Koch. Respect the relationship when we do caval snaring, especially in the SVC. Don't snare over the SA node, and also respect the aortic segment of the annulus. Don't hit the aortic root or the aortic root or the aortic valve. It is it's a fair in a primary surgery for mitral valve. I think we should give the best chance for the patient to address his tricuspid valve, just to avoid the very lethal late tricuspid valve regurgitation. People can have low threshold to address tricuspid valve if there is elevated PA pressure, dilated annulus, patient has atrial fibrillation. Previous reports tells you that patient was in congestive heart failure or having lower lymphedema, or his RV is dilated and the right atrium is also dilated. For the subset of patients who had previous surgery for the mitral and came with severe TR, you need to know more about these patients, admit them, rule out constrictive pericarditis, know how much reserve you have in the liver, and see their response to diuresis, and don't take the decision in a hurry. Thank you.
Thank you very much, Dr. Nazeer. Very, mashallah, tabarakallah. Great lecture. Floor is open for question, kindly.
Dr. Nazeer, are there any other cases where you would consider replacement over repair, apart from having a very irreparable valve? What would make you go for replacement straight away?
Yes, so replacement of the tricuspid valve, I think just by knowing the anatomy of the tricuspid valve relationship to conduction, replacement is not a good idea. I know people tell you to take the sutures over the leaflets, but the reality, if you see the leaflets, they don't hold sutures. So you actually put them on the annulus. You might not get a heart block immediately. The rate of late heart block is very high. I think for this very anatomical relationship, tricuspid valve replacement is not a good idea. Reconstruction is better in all cases, even tricuspid stenosis. Pioneers of surgery of tricuspid, Carpentier, and all others, they prefer reconstruction even in extreme situation. But the message is, don't keep a low threshold for replacing the tricuspid valve. One more problem with replacement, not only heart block, future heart block, for any reason, you cannot place a pacemaker through the tricuspid valve. You are risking also infective endocarditis, prosthetic valve endocarditis of the tricuspid valve. No low threshold for tricuspid valve replacement in general. No, in terms of evidence, no evidence. Nobody can tell you replace or repair, but all observations data tells you repair is better in terms of survival and everything. There is no randomization.
I see. The current cases of stenosis, you rarely get isolated stenosis, usually with a degree of regurg, which makes repair a bit feasible. But if you have that rare incidence of a purely stenotic valve, would you still consider repairing it? With only stenosis, no regurg, which I understand is quite rare.
Yes, you consider repairing a tricuspid stenosis, rheumatic, if repair is easy. If it is just commissural fusion, you can splice the commissure. And the principles of commissurotomy is that don't let your commissurotomy reach the annulus. Leave always part of the leaflets attached to the annulus. If that does the job and the leaflet's quality is good, they are pliable. That will do the job. If not, then there is a chance to augment the leaflets if they are fibrosed. You can augment the leaflet with autologous pericardium. And I think still the result would be better than replacement. But you have, in case of stenosis, your threshold for replacement would be a little bit higher.
Clear. One last question, if I may, Doctor. In the case of isolated tricuspid disease, I know the indications are quite vague, but have you operated on isolated tricuspid valves, and what was the indication, or what would make you do so?
Yes, so this is a case for the mock. The next case is going to be an isolated tricuspid valve disease. We'll discuss it in the next mock test.
Okay.
Okay.
Thank you, Dr. Nadir. When you are coming off cardiopulmonary bypass, which degree of the tricuspid regurg make you go back? I know this is depend on the patient situation, it's critical or not. So, but there is another factor to consider, or you will accept mild to moderate?
This is a very difficult question in real life, but theoretically, I would say people shouldn't accept more than mild tricuspid valve regurgitation. But you should not accept more than mild or moderate tricuspid stenosis. It depends on the situation. If you have severe, definitely you have to go back and address it. If it's moderate, then it's a question of judgment. It's a judgment call, depending on the situation, and also weighing the risk and benefit of going back, snaring, and considering replacement of the tricuspid valve. Replacement is not good. If you can address it on a beating heart, doing a Clover technique or semi-bicuspidize a tricuspid valve, that would be a good idea.
Thank you. So that's mean if it's moderate under anesthesia, that's equal to severe without anesthesia. So if you are leaving moderate, that's mean severe. If you are leaving mild, that will be moderate after surgery, right?
Not necessary. Not necessary, because you are coming off bypass, the RV is dilated, myocardial protection depending on the length of surgery. A lot of tricuspid valve regurgitation, they get better. From moderate, they get better, because immediately after bypass, the most affected chamber is the RV, and it's dilated. So that will cause stress on the leaflets. It's unlike the mitral valve. So you can get actually a tricuspid valve regurgitation after coming off bypass in a normal tricuspid valve.
Okay. Okay. Thank you, Doctor.
Thank you. Thank you, Hussein. So Haitham, can we go to the mock test, mock case?
Kindly, boss.
Yes, who is going to take it, or is a group answers?
No problem. I can start.
Okay.
Or Hussein or Faisal, if you like.
Yeah, no problem. Excellent. So this is a case of isolated tricuspid valve regurgitation because we did not have room to do it in the common presentation. It's a real case, 50-year-old engineer who presented with NIHA class 2, and he was in atrial fibrillation and referred to you as a case of tricuspid valve regurgitation. So we'd like to go through this case until we do the surgery on him. So let's start with clinical exam. This patient came to your OPD with this possible diagnosis, and you examine him clinically. What do you look for in brief? 2 or 3 things.
So he's a 50-year-old male. He came to me that I know he has atrial fibrillation,
Yeah.
which proven to cause currently the tricuspid regurg.
Yeah.
The most important things for me in clinical sign, when I need to take details, history first of all, but I will go directly here in the question, the clinical signs. I need to know the sign of right heart failure. So I will look for rise GVP. I will look for any ascites in the history and in the examination that happened to him. Also, pitting edema. All this, it's very important to me to know the degree of the severity of tricuspid regurg that he has.
Oh, excellent. So you look for signs of congestive heart failure, raised JVP, abdomen for ascites, liver enlargement and tenderness, pulsatility of the liver, and lower limb edema. So let's JVP. Let's integrate basic knowledge with clinical knowledge. So the JVP in these patients, if you have a paper and pen, and you are asked to draw the central venous pressure waveform for this patient. You can draw it if you have pen and paper now, or you can tell us the features, just in general, central venous waveform. What would it look like in this patient?
So he will have a high A wave because of increased pressure in the right atrium. Suppose he has he has severe TR. So it is A, B, no, A. It is five waves, which is A.
You have the positives are A and V, and there is a notch, a little bit pump up of C, interrupting the X descent. So what changes? This is a normal central venous waveform is A positive, V positive, X and Y descent, and there is a little C pump on the Y descent.
Yeah, so the Y, I think the Y descent will be even higher with this patient because of the regurg.
I think, Haitham, it will be small A and large V wave because of the regurg.
Correct. Anybody wants to say something else? Rest of the group.
I think it's as Hussein mentioned, the descent V will decrease A.
The Canon wave with DS, I think, not with this one.
Yeah. So he's in atrial fibrillation. So if you have atrial fibrillation, you don't have A wave. Agree?
Yes.
Yes.
Basically, you don't have an A wave. You have, and tricuspid valve regurgitation leads to elevated V wave, which is a systolic activity. And V merges with the C. So the first wave of the central venous waveform of this patient will be a large V wave, no A wave in the beginning. So it will be just like one wave coming up and down in this patient. nearly similar to an arterial wave. So, because normally, if you observe an arterial wave and a venous wave, arterial waves come up and down, just one systole and diastole, systole and diastole. Venous waveform, it goes up in atrial systole and comes down. And again, with atrial filling, it goes up again a little bit. So you see biphasic wave. In tricuspid valve regurgitation with atrial fibrillation, you get just one wave like that. So almost like an arterial wave. So drawing normal intravenous pressure is nice. Some people ask about, and it's good for integration of clinical knowledge with the clinical or with the basic knowledge. You can have sometimes students asking from other departments attending you the clinic. They might ask you. It's not really relevant to the surgeons, but in exam situation, it is relevant.
Okay.
Now, this is you are reviewing the echocardiograph, and then this is a 4-chamber view for with scalar Doppler and without, and you can see. Can you read it, Haitham, please?
Okay, so this is an apical 4-chamber view, which showed here is severely dilated. So this is severely dilated right atrium. The cohabitation of the tricuspid, although it's not even severe dilated tricuspid valve annulus, and I need to measure it, and there is lack of cohabitation. I'm reading now on the left side, lack of cohabitation on the tricuspid valve. RV from, I don't have the full view, they are concentrating on like 3-chamber view, not the 4-chamber view. It seems also from this view is dilated. In the right side, we can appreciate trunchial MR because of the lack, sorry, TR, because of the lack of cohabitation of the leaflet. Even the intraventricular septum, you can appreciate is pushed toward the LV, most likely because of the high pressure, but of course I need further view to comment on that and to comment on the ratio size between the RV and the LV. The insertion of the tricuspid valve, it's corresponding from this view, but I need also another view to clarify that. It's corresponding to the mitral. I cannot see any displacement of the insertion of the tricuspid, but still I need maybe further view just to confirm that it's like a little bit apical, but maybe I'm wrong. I cannot judge from one view.
Yeah, it's apical a little bit, but it's not that significant to be abnormal.
Yeah, but I mean, I'm just commenting about this one, so I need the 4-chamber just to be sure, but mitral seems in the same level here. Did I miss anything, or Hussein, if anyone think I miss, or after, then Dr. Nadir, he can comment. There is something in RA, I don't know, is it artifact or, you know, the base of the RA here, it's like, I don't know, is this band or artifact or?
The top.
Okay. So this is, yeah, so it's an artifact icon.
Okay.
So great, this is very, very beautifully read echo. Anybody would like to know the annulus of the tricuspid valve here?
Yeah, we need to measure it, hinge point to hinge point. What is what's the diameter of this annulus?
So how is it going to help you?
The annular diameter?
Yes.
Just okay, that will tell me if it is, sometimes I have acute problem leading to this. However, there is no sign of infective endocarditis or trauma from this view. But if it is really severely dilated, that tells me this is a chronic process, not an acute one. But everything is going with a chronic process with this echo. and it
Yeah,
will help me with planning of my surgery if I want to plan surgery later.
mainly to differentiate functional from organic tricuspid regurg.
That's a good point also. So my point is, if you have severe, the annular will have the annular diameter is not essential in decision making, but it is probably, as you mentioned, useful to know. And of course, in this view, you will not get an accurate annular assessment. It is not RV focused for chamber view. But in the algorithm for annular diameter, it is not there. You don't need it because it's already severe. That makes sense?
But what?
That makes sense that it will not influence the decision. It might help just knowing, but it will not influence the decision in the algorithm of decision making. If the trackers with here, you are not looking for the annular diameter to make you decide for surgery or not surgery, right?
Yes.
Yes.
In general. Great. So, so what other information, Haitham, you are looking for? So you have an established severe or torrential or massive tricuspid valve regurgitation. So
Okay.
what else you want to know from the echo people? You are sitting beside the echocardiographer, and you want more information on transthoracic echo.
For more information, I need to see all the echo. This is long axis parasternal view and showing good cohabitation. First of all, the LA seems normal in size. The LV actually here is small, and RV is large. Seems, I can say, dilated, but functioning well, maybe some mild dysfunction. And really, and the symptom is pushing the RV. Mitral valve is cohabitating with good cohabitation, anterior and posterior mitral leaflet, with no obvious pathology on it. Even the aortic valve is the same. Ejection fraction, left ventricle ejection fraction from this view seems to be within normal. I think that one is dilated. This one LV, so pulmonary.
Yeah, so it's a beautiful, beautiful description, I think.
The BFO, I think I need color here because I'm not sure is this also artifact or this is the area above the aortic valve, but this is like the aortic valve and the RV. No, I think this is artifact, nothing. But more view.
If I may, Doctor, I think I want to know a bit about the RV function, pulmonary hypertension, and because of AFib, I want to make sure there's no PFO that. No, never mind. That's fine. I think just the pulmonary hypertension and the RV function probably.
And LV function as well.
Yeah, of course.
Pulmonary vein dilated here. We can see it.
Yeah.
So that indicates a higher pulmonary pressure from that RV because the mitral and LV and LA seems within normal from this view.
Excellent. So if you have an isolated right side, you want to make sure that the left side is okay. It's not secondary to left side problem, especially the mitral. It is basically the mitral. If the mitral is okay, so this is not a functional tricuspid valve regurgitation resulting from mitral.
Yes.
Most common pathology people deal with. So that's good. Looking at the mitral, aortic, LV dysfunction, and of course shunts. You want to look for shunts. And your question of
this is ruled out. This is a couple test actually in the apical four-chamber view, and there is no shunting between the right side or RA to the to LA with the agitated saline.
Excellent. So no shunts is detected. No shunts, no left side. Mitral is good. Aortic is good. LV function is reasonable.
But here also indicating severe, this is indicating severe RV, يعني the size of the RV, it's almost double the size of the LV here.
And you can see the paradoxical movement of the septum. So that's probably indicating right RV pressure, high RV pressure.
Okay. So what else do you want to do?
An investigation.
Thoracic did not show you echo. T did not show you a shunt. Transesophageal did not show you a shunt. Left side valves are normal. LV function is normal. What else do you want to know?
He's a 50-year-old. I want to rule out any other causes, maybe one of the rare causes. About one of the workup in 50-year-old, I need to do cath. So for him, I need left side, also the right side heart cath to check for the RV and, the pulmonary hypertension, and also to determine the degree of the RV dysfunction of this patient. And the coronary angiography also, it is important to me to know before before deciding.
Excellent. So you are doing left and right heart cath, being 50-year-old. So let's start with the right heart cath. What do you want to?
In the right heart cath, the information I want together with this patient is the RV. The most important thing is the pulmonary pressure with this patient and pulmonary gradient. And after, of course, the index, and to know the degree of pulmonary hypertension. This is the most important question I want to know.
You also want to rule out pulmonary embolism, massive pulmonary embolism.
Yes, Faisal. Okay. How can you do that on right heart cath?
I think there'll be a filling defect.
On CT.
That's on CT, not in right heart cath. Heart cath can give you a hint.
It can give you a hint to the high pressures, I guess.
Exactly. So the PA pressure can be measured directly, invasively. So anything you want to add, Dr. Hussein?
And the right heart cath, yeah, that's all.
Excellent, excellent. So whenever right heart cath is mentioned, you will be asked about cardiac output measurements. And PA pressure is directly measured. Once the cath is there, the pulmonary catheter is there, you directly get measurement of the PA pressure. And you go until the wedge. So probably, maybe you will be asked, if you have a paper and pen, to draw the waveform from right atrium RV, how the waveform changes until it reaches the wedge. I will not ask you about this, but let's say you reach the wedge, the PA pressure was not high, but how do you measure pulmonary vascular resistance?
Pulmonary vascular resistance, it will be
relevant. Relevant. Is it relevant in this case to know the PVR?
Pulmonary vascular resistance, yes, because of the etiology.
So let's see what is the formula for.
I think pressure and SVC multiplied by pulmonary artery plus pressure in the aorta multiplied by.
It's simpler than that, Hassan. Way simpler than that. Okay.
I have mind block.
We mentioned transpulmonary gradient.
Divided by the cardiac output.
Exactly. Who said that, Osman?
Osman.
Osman, what did you say?
Pulmonary vascular resistance equals to the transpulmonary gradient divided by the cardiac output.
Amazing, excellent. So the transpulmonary gradient is the mean pulmonary output pressure minus the wedge. So you measure the mean of the pulmonary artery divided subtract from that the wedge and divide it by cardiac output. Excellent. The next question is how to measure cardiac output. How to measure cardiac output by doing right heart cath. So right cardiac output needs to be measured. The question will come, how do you measure cardiac output in general? What techniques?
You can do thermodilution to measure cardiac output.
Okay, this is one way.
And Fick study.
Yeah, Fick equation.
And these are the two. If you are to choose between fixed principle and thermodilution, which one will you choose in this particular case?
Fick.
I think I'll go with Fick here.
You know why?
Because of the TR.
Not correct with the TR.
You send the patient for cath lab. You don't know who's in the cath lab doing the cardiac output measurements. It could be a resident, could be somebody interested in right heart cath. If he ask him, how did you do the cardiac output, and tells you that he did the thermodilution, you know that he did not at the echo. He doesn't know that the patient has to do tricuspid regurgitation. So you need to monitor your patient test. Fixed technique is used. You don't like it in the cath lab because it requires measurements. What is the fixed equation?
Hemoglobin multiplied by oxygen saturation in the artery minus mixed venous divided by 100.
Okay.
I know the component. It entails the hemoglobin, the oxygen saturation, and the partial pressure of oxygen. But the equation itself.
So what is the general principle? What does it say? The main equation for fix. The fixed equation is I think it is more than how many years? 18. It's very old formula. Very old formula. So what is the general formula? Just the general plan. It is, they don't like it in the cath lab. So that's why you have to ask if they use it in your case of tricuspid valve regurgitation, because it requires multiple trips, taking saturation from here, taking saturation from there, waiting for the results, do the calculations. So the general equation of fix says that oxygen delivery equals the cardiac output times brackets arteriovenous oxygen content difference. So this general equation should be memorized, and then it comes to the details. How to calculate the oxygen content of a sample of blood. Then comes the hemoglobin concentration, the saturation, and the solubility factor of oxygen. But the general equation for fix, I think, needs to be memorized. So you get measurement of the cardiac output and transpulmonary gradient, you get the PVR. So in these patients, if they tell you the PVR is, let's say, 3 Woods unit, is that satisfactory?
Less than four. It's not significant.
Excellent. So they did the left heart cath in this patient. He doesn't have severe PVR, and they were still pursuing the reason for an isolated tricuspid valve regurgitation patient. They did the left heart cath for coronaries, and this was the finding. This is the injection of the RCA. This is actually part of the finding. Unfortunately, I could not get all the images. So does it explain anything? Just try to. It's not an exam, but let's see what you think of this image. Does it explain the TR?
If this RCA, it's tortuous and dilated, that's most likely will associated with fistula, coronary fistula.
Perfect.
And that may explain that right heart failure and TR.
Perfect. That was the reason in this patient. He had multiple fistulae coming from the coronary. The one you see here is only coming from the RCA. There is another one coming from the circumflex, and another feeder coming from the aorta itself. They tried to coil. They put a coil in one of them, but they couldn't control all the fistulation. So that patient had to go for surgery.
So it is the reason is left to right shunt from this fistula.
Yeah, chronic left to right shunt. I think he was born with it. He grew until you see that bad image of the right side. Fortunately, his RV function was maintained. He was not in severe condition. His liver function was okay, and he underwent tricuspid, you can imagine. So no leaflet. He had tricuspid replacement in this patient without struggling with repair.
So, Doctor, for the RV, for the RV function, is TAPSI in the adults applicable or reliable, or is there any other ways to assess the RV function?
So yeah, this question is very, very good. TAPSI alone is not enough. TAPSI alone for tricuspid, for right ventricular function is not enough. There is TAPSI, there is PAPI, there is fractional shortening of the RV. There are the dimensions of the RV related to the, compared to the LV, and whether the RV causes form the apex of the heart or not. So a lot of things are taken, invasive and non-invasive techniques are used to assess the RV function.
Clear.
Can I ask one question, Doctor? Do we have to do a right cath for all patients with tricuspid pathology?
Isolated tricuspid.
Isolated tricuspid.
So one more question, Doctor, if I may. So if this patient had a OD unit of 4 or above, would that be a contraindication in an isolated tricuspid valve disease?
Probably yes. Yeah. Severe pulmonary hypertension with 4 units, more than 4 will give you severe pulmonary hypertension, and these are the patients you shouldn't take for surgery. Because you are not correcting the pathology, you are just going to hear the RV. Just investigate for the cause for high PA pressure, with a chronic thromboembolic disease, pulmonary thromboembolic disease, or related to left side problem, and it is common in congenital heart disease also.
Clear. Thank you.
Doctor, how you manage this patient?
So we just decided from the start to replace the tricuspid valve. If one of you can show me the conduct of surgery for an isolated tricuspid valve surgery.
No, I meant for the fistula.
Oh yes, that's a good question. So once we opened we did it throracotomy and beating heart on bypass, peripheral cannulation, and fortunately, all the feeders were determined by CT scan and angiograms before surgery. So once we opened, we found an AV malformation in the hilum of the right lung. It was huge. And there are feeders to that AV malformations, discrete feeders, 3 of them coming on the roof of the right atrium, feeding that AV malformation, and one big vessel draining into the IVC. So what we did, we just picked those feeders one by one. We ligated them and cut them between ligatures. And then we could see in front of our eyes that the whole AV malformation collapsed. We ligated that feeder to the IVC, and so that way we addressed the AV malformation. And then we opened the right atrium and replaced the tricuspid valve. The leaflets were nothing, no substrate to repair. So you don't have much to try repair. We replaced it on a beating heart using bioprosthesis. It has been now, I think, more than 5 years, and he's doing well. He did not require pacemaker, fortunately. so far.
Alhamdulillah.
Yeah, alhamdulillah. That's it. Anything on the?
Very nice case. But why, Dr. Nadir, why you went thoracotomy?
Why we went for thoracotomy is we first of all he's relatively young and he's an engineer. He preferred less invasive. This was preference. And second thing, we felt that we could address the pathology through thoracotomy. And that was because we had a good plan. We know the anatomy. We know the heart is huge. You can imagine where is that tricuspid? It's just hitting your chest wall. So
yes.
So it was thoracotomy. But you can still go for anatomy if you feel that is safer.
طبعا انا I'm asked because يعني this is complicated. I know يعني for you, for the others يعني Dr. Nadir is a consultant adult cardiac surgery, minimally invasive cardiac surgery. Also he's doing adult congenital cardiac surgery. But I'm asking Dr. Nadir because just to know if there is a specific reason.
So it's just people like minimal invasive. If you can fix it through minimal invasive, that would be better. But of course, no guidelines to tell you what approach to do. You use the safest approach for the patient.
Okay.
The safest and within the skills available in the hospital. Skills means not the surgeon's skills, everybody's skills. Anesthesia, you need special anesthesia skills for minimal invasive, your colleagues, scrub nurses, and the presence of tools. Good. So you want to take a break for the next presentation? We can go right away.
As you like, boss.
We want to take like, it's now 9, and we can start 10 o'clock. No, not 10 o'clock, I mean 9:30, short break.
Okay. Okay.
That will be another very small presentation, inshallah.
Thank you. Thank you very much.